Essentially just the background. We need to know that hypertension, poorly controlled, detected and managed around the world, and that's been known. We know that statin use is not optimal, less than 5% of patients with hypertension, and yet it reduces cardiovascular disease in these patients. So we needed to address this gap. And the big thing that we did was we assessed barriers to care and why was this happening, tried to sort this out. We worked specifically in Colombia and Malaysia, but did health systems appraisals looking at barriers at the patient, healthcare provider, and health system level. We also did systematic reviews looking at what information in the literature exists as well. This all informed our intervention, which was really had three core components. One was task shifting to non-physician health workers that were supported with tablets to help with the screening, diagnosis, and counseling of cardiovascular risk and hypertension. We did provide free combination single pill antihypertensives as well as a statin, which was recommended by the non-physician health worker but supervised by primary care physicians. And then finally, we involved family and friends in this whole intervention to try to improve adherence to medications as well as to healthy behaviors. So we did a cluster randomized controlled trial involving 30 communities, 15 in Colombia, 15 in Malaysia, with patients who were 50 years or older with new or poorly controlled hypertension. Our primary outcome was out of the Framingham risk score, a change from between intervention and control, and we demonstrated that there was an 11% absolute drop in the Framingham risk score in the intervention group with only 6.4% in the control. So we had a greater than 40% reduction in cardiovascular risk, which was strongly positive. We also demonstrated significant reductions in systolic blood pressure of greater than 11 millimeters of mercury, and that's between intervention and control. From baseline, it was greater than 20 millimeters of mercury. We also demonstrated significant reductions in LDL. We showed improved medication adherence as well as healthy behaviors were improved. The medications we used were all generic, locally available. So that would be the case and could be applied anywhere in the world. To the involving family or friends. I mean, this is something that's free of charge. It's just kind of actually actively getting them involved, and we do feel this helped with our adherence and healthy behaviors. Finally, the non-physician health workers, many countries have these already employed in different areas, HIV, maternal health, and there is the question of can we repurpose or even add on cardiovascular risk prevention. And I think this can also apply to high-income countries. They're being used often in clinics and elsewhere. Why can't we kind of go out into the communities, particularly in lower socioeconomic status communities that maybe have disadvantaged populations that aren't getting the appropriate medical care? We can kind of get in there and make the biggest difference. So I think there is the possibility for scalability. The actual core components would likely be the same, but then there may be tailoring depending on the different countries that would adapt this, and that's what we'd recommend.